أقدم أستاذة الدكتورة ماجي عبدالوهاب Professor of Hematology Cairo University وهتكلمنا على the liver a key organ in hemostasis the clinical implication.
Thank you so much for the introduction. والحقيقة المحاضرة كلها in a nutshell في الدياجرام ده. Okay. Okay, topics to be discussed. The coagulation cascade, procoagulants and anticoagulants. The key role of the liver in hemostasis, highlighting its role in the neonates and infancy. Pathophysiology of coagulopathy and thrombosis in liver disease in children that can impair hemostasis, introduction to the clinical importance of liver disease to hemostasis by a case study, clinical implications of hemostatic dysfunction in the liver, management of hemostatic dysfunction in the liver, and take-home messages. Actually, take-home messages in this presentation is very important. Okay, the process of hemostasis. It can seem to be complex, but I will try to simplify it. In very simple terms, hemostasis, that means when you are injured, the blood loss stops. How does this happen? Actually, in itself, it's a miracle. There are so many stages happening, but in no time, the bleeding stops and we don't know what happens. And what's really miraculous about it is that everything is happening at the same time. Okay, so here, actually I want to point here, instead of the, okay, there's a pointer. Yes. Okay, so here, we have the vessel injury. Okay, so at the same time, and then I'm starting the sentence by at the same time. What happens here? Tissue factor is released, okay? And first of all, there will be vascular spasm. So vasoconstriction will happen instantly to minimize the blood loss. And here, when the vessel injury happens and then vasoconstriction takes place, at the same time, the process of primary hemostasis starts. And the key role player here is the blood platelets. So the injury of the vessel exposes the collagen fibers and causes platelet adhesion. Platelet adhesion then and aggregation that leads to release of ADP. Okay? At the same time, the tissue factor acts on the thrombin and fibrinogen, and the thrombin converts fibrinogen to fibrin, forming the hemostatic plug. So everything is happening at the same time. And also, we are having the coagulation cascade working with us. So the fibrin here will form a mesh, okay? That mesh is friable. To form the stable hemostatic plug, there's got to be stabilization by factor 13, okay? Which leads us to coagulation phase, or the fibrin-thrombin formation, what we call secondary hemostasis. In very simple terms, if we remember from physiology, the activation of the coagulation cascade proceeds nearly simultaneously with the formation of the primary hemostatic plug. Again, so everything is happening at the same time. It's one and the same process. The goal of the cascade, the only goal, is to form a stable fibrin clot at the site of the vascular injury, as we saw in the previous diagram. The coagulation cascade is a sequence of enzymatic events that we are going to see later in a cartoon. Most plasma coagulation factors circulate as proenzymes, and afterwards they are activated by the activated factors that precede them in the cascade. Hemostasis must be restricted to the local site of vascular injury. وده من رحمة ربنا سبحانه وتعالى. لأن the size of the primary and the secondary hemostatic plug must be restricted to the vascular lumen to remain patent. Otherwise, هنخش the other end of the spectrum, thrombosis. Okay, in this cartoon, what do we see here? So, after the injury happened, okay, we saw the primary phase, which constituted the platelets. And then there was the release of the tissue factor from the damaged tissues. Okay, and that will form later on the factor 7-3 complex. Okay, if you remember in the first diagram, the injury exposed collagen, and that led to activation of factor 12, factor 11, all in Roman numbers, factor 9, factor 10 activator complex. And that actually will lead to the prothrombinase complex. Prothrombinase complex, this is very important. This is the key role player. Okay, what does activated factor 10 does? It activates prothrombin to thrombin, and thrombin activates fibrinogen to fibrin. Does this stop here? No, it does not stop here. There's factor 13. It's always forgotten, and it's very important. This is what stabilizes the fibrin clot. What do we see here? Okay. So, again, this is something that only this step is repeated. I mentioned previously. So, when the vessel wall is injured, tissue factor is exposed to the circulating endogenous factor that's activated factor 7A. If you remember, that was on the left side, the extrinsic pathway. So, if you remember in the previous figure, where did we mention we mentioned thrombin here, okay? But then here, we are mentioning thrombin again. Thrombin is released twice, okay? Minimal amount is released to activate the platelets and factor 8 and factor 5, okay? Because if you remember, I said platelets were activated. No one asked how were platelets activated. So here, thrombin is released to activate platelets. And that is really a sophisticated way of explaining the secondary hemostasis. So activation of factor 10 here, what we will form the prothrombinase complex. It leads to the formation of the prothrombinase complex. Okay? These are the common pathway factors, factor 10 and factor 5. They subsequently generate a very big amount of thrombin, what we call the thrombin burst. This thrombin burst, it leads to the generation of hemostatic plug that prevents further blood loss. And then the factor 13 stabilizing the blood clot. أنا عارفة هو الفيجر ده شكله complex، لكن أنا I will focus على حاجات. هو أنا I'm building up من first diagram ده آخر كده diagram إن شاء الله. Okay, the thing is, there is a balance between coagulation and anticoagulation in the body to prevent thrombin formation under normal conditions. Propagation and to maintain blood fluidity. القصة إن كل factor له procoagulant وله anticoagulant علشان a balance the process in very simple terms. So anticoagulant system exert its regulatory effect over procoagulant activity to localize the thrombus formation. So abnormal hemostatic system may produce abnormal bleeding, pathological thrombosis, أو both. Okay, ساعات بيبقى عندنا حالات بيبقى فيها bleeding and thrombosis at the same time. علشان الأمور تبقى متعادلة لازم يبقى فيه process of fibrinolysis. أنا بعمل fibrin clot لازم أدوب الفibrin clot دي. Removal of the physiologically deposited clot. It's brought about by the action of plasmin on fibrin. Okay, so plasminogen is converted to plasmin by several factors, most importantly by the tissue plasminogen activator. The key role in mentioning all this details the coagulation cascade is to show you the role of the liver in manipulating all this. The liver is very, very important, as we are going to see later. So, and here I'm putting hemostasis in children. It's very different than hemostasis in adults, and especially hemostasis in the newborn. The hemostatic system in healthy children, and this is very important, is thought to contribute to decreased incidence of spontaneous bleeding and clotting events, unlike adults. But unfortunately, when the bleeding or thrombosis take place in children, there's higher morbidity and mortality. And hemorrhage in the context of a liver disease can be life-threatening, especially if it's from the GIT, like we encounter in vitamin K deficiency, or cerebral bleeding, like we encounter in inherited coagulopathies, or in some metabolic disorders, as we are going to see later. And also thrombosis in children, especially portal vein thrombosis, can be very serious. The concentration of coagulation proteins and inhibitors differs from adults, especially in the neonatal period and infancy. عارفين معانا حد neonatology ولا لا؟ So neonates have a higher levels of von Willebrand factor, factor 8, low levels of vitamin K dependent factors 2, 7, 9, 10, protein C and protein S. وعلشان كده vitamin K supplementation is used worldwide in breastfed infants. The levels of plasminogen and antithrombin, and that's why I mentioned them in the previous slide, are low in neonates, which might be of importance considering its role afterwards. The level of another thrombin inhibitor, it's called the A2 macroglobulin, also is increased in neonates and remains high in later childhood and adolescence. The importance of all this is to see how hemostasis works in the liver. Now, very importantly, the liver itself does not seem to regulate the developmental changes of the hemostatic system. طيب وايه البروف على كده؟ Liver graft from an adult donor produces coagulation proteins according to the age-specific pattern. يبقى الموضوع كله مرهون بالage. كل الchanges دي according to the age. Okay. يبقى البنوتة ديت بتقول إن liver has a central and critical role in sensitizing the majority of the coagulation factors, the anticoagulation factors, proteins involved in fibrinolysis, and thrombopoietin. Thrombopoietin ده مهم جدا for the production of platelets. عشان كده the role of the liver is intertwined in coagulation with the function and the number of blood platelets. طيب. What's the impact of liver disease or cirrhosis, because that's the end stage, on hemostasis? Acute or chronic hepatocellular diseases and hepatic failure, including liver cirrhosis, vitamin K deficiency, liver surgery, and liver transplantation, or actually including liver transplantation, show various hemostatic abnormalities in the coagulation system, fibrinolytic system, platelets, and the reticuloendothelial system, because it removes the activated factors. Okay, so in liver disease, we have tendency to both a coagulopathy or bleeding and tendency to thrombosis. Why do we have a tendency to a coagulopathy? Because of thrombocytopenia. Why thrombocytopenia? Because of decreased thrombopoietin and increased splenic sequestration secondary to portal hypertension and splenomegaly. And also, there is an element of platelet dysfunction, which is not known why. Okay, vitamin K deficiency will comprise the production of factor 2, 7, 9, 10, antithrombin, protein C, and protein S. And protein S is called the vitamin K zymogen. The deficiency of antithrombin, protein C, and protein S lead to thrombosis. There is elevated levels of markers of platelets activation, thrombin, and fibrin degradation, and fibrinolysis. Okay, and this can be due to a low grade of DIC, or decreased hepatic clearance associated with hepatic pathology. The severity of hemostatic dysfunction correlates with the degree of impairment of the liver. When the worse the liver condition, the worse the coagulopathy. What about thrombosis? Like we said here, these patients have low antithrombin, protein C, and protein S because of the impaired synthetic function of the liver. Okay? So, when thrombosis occurs, mainly in infancy and teenagers, there are several risk factors. What we call loss of reserve in the anticoagulant system. So these patients can have hereditary prothrombotic disorders. Actually, in the Egyptian populations, in the pediatric age group, we have several mutations that lead to thrombosis. They are not the factor V Leiden or the prothrombin mutations like the Western world. We have, for example, a much commoner mutation, the methyl tetrahydrofolate reductase, and associated with other mutations. There is reduced blood flow, endothelial dysfunction. All this will lead to thrombosis. And this is actually consistent with the Virchow's triad. حد فاكر Virchow's triad بتاع الثرومبوسيس؟ طيب كده in a nutshell what happens to the liver. هنا عندي bleeding وهنا عندي thrombosis. Okay? Why are patients with a liver disease, a significant liver disease, predisposed to thrombosis? They have decreased vascular flow, they have endothelial damage, they have increased von Willebrand factor, increased factor VIII, and both are prothrombotic, decreased protein C, protein S, antithrombin, and decreased plasminogen and plasminogen activating factor. On the other hand, these patients are liable to bleeding, okay, because of the decreased coagulation factors 2, 5, 7, 9, 10, and 11, okay, as well as decreased plasmine factor 13. هتطفوا النور؟ okay. الفيجر ده بيبوينت كمان للبليتلت ديفكت other factors زي الهيمودايناميك changes والفاسكولار damage والportal hypertension اللي موجودة في liver disease. Thrombosis, there are many factors leading to thrombosis, and amongst these factors are decreased level of Adams 13, as well as low levels of plasminogen, and we mentioned before the inherited thrombophilia. Okay. Chronic liver disease in children represent a rising problem with significant effects on public health. The spectrum of pediatric liver disease has changed. There is increasing number of inherited and metabolic liver diseases as opposed to infectious diseases, showing a decreasing trend. Now, very importantly, the clinical manifestations caused by inherited metabolic diseases might be under-recognized or misdiagnosed due to non-specific characteristics, so leading to delayed diagnosis with subsequent complications and or liver cirrhosis and clinical presentation with hemostatic abnormalities, as we are going to see later in a case review. Very importantly, detailed studies of hemostatic disturbances in the setting of the pediatric liver disease are sparse. So what we do is we project what we call extrapolation from adult studies, and this is not appropriate, as both the spectrum of liver diseases, the hemostatic system itself, as we saw, differs between children and adults. I think this is very important because of liver transplantation also. So the pediatric patients with the coagulopathy of liver disease present a complex set of problems that include both bleeding and thrombosis risks. So the pediatric hematologist is called on to evaluate and treat. And this is what I want to highlight. The hematologist and the hepatologist, they need to work together. There is significant lack of pediatric studies to guide the clinical decision making. So the majority of this discussion and management of hepatic coagulopathy is based on adult studies and guidelines. So we need to have our pediatric guidelines. So this is a 10-month-old boy who was admitted at the age of 40 days because of rectal bleeding, which was followed by disturbed consciousness level and seizures. Okay? CT brain shows intracranial hemorrhage. The laboratory tests confirm the coagulopathy, typically prolonged PT, PTT, and mild because we have the common pathway involved. We do two coagulation factors, 2, 5, and 10. So the patient had mild factor 2 deficiency. Fine. The patient probably had inherited factor 2 deficiency, which is very, very rare, 1 in a million. But because I'm interested in rare coagulation disorders, in our population, by the way, the rare coagulation disorders is not rare. It's 10%. It's more than hemophilia B. Okay. So patient was treated with FFPs, fresh frozen plasma, and vitamin K. Fine. Then recurrent attacks of intracranial hemorrhage occurred, and few months later, the patient developed a mild degree of jaundice, which proved to be cholestatic in nature and improved spontaneously. A mild synthetic dysfunction of the liver was evident, and tyrosinemia was put as a possibility, and alkaline phosphatase and alpha-fetoproteins were markedly elevated. To confirm the diagnosis, of course, of tyrosinemia, plasma succinyl acetone, tyrosine, and methionine were measured. So, overt liver failure with coagulopathy is one of the well-known presentations of tyrosinemia, but a significant coagulopathy without any liver impairment is definitely not a presentation of tyrosinemia. So we have to think, if we encounter such patients, not just inherited coagulopathies, but it can be a manifestation of an inborn error of metabolism. So, these are specific circumstances in specific pediatric liver disease with distinct impact on hemostasis. Although coagulopathy, bleeding, and thrombosis, by coagulopathy I mean bleeding and thrombosis, may occur in any type of liver failure, some specific diagnoses are more reported to be associated with a coagulopathy. Specifically, inborn errors of metabolism, as we saw before. And of course, we know that bleeding occurs in vitamin K deficiency, secondary to cholestasis, as we saw in previous presentations yesterday in biliary atresia, Alagille, or alpha-1 antitrypsin. Also, thrombosis is described in liver abscess and cystic fibrosis in children. And even Gaucher disease, they can have bleeding due to liver cirrhosis. I'm not mentioning the thrombocytopenia because of bone marrow infiltration. I'm mentioning here the bleeding due to liver cirrhosis, and also they can have what we call acquired von Willebrand disease. Okay, this concept is very important, and it's been mentioned in adults, but it does not work in children at all. And it's very important for liver transplantation, and it's very important for anyone managing a liver disease with a impaired coagulation profile, especially the INR. The concept of rebalanced coagulation has been developed to explain the changes in the counteractive procoagulant and anticoagulant mechanisms. By that, I mean what? The extensively used hemostatic assay, the INR, it's very good and very important for patients on anticoagulants, but it's not predictive of a bleeding risk in patients with liver disease. It was long thought, and especially in adults, that a patient with liver failure and an increased INR cannot per se be regarded as anticoagulated. So it was thought before that these patients are naturally, not naturally, they are pathologically anticoagulated. And this is not true. Clinical implications. The detailed studies of hemostatic disturbances in the setting of a pediatric liver disease are sparse. They're quite rare. Extrapolation, as I said before, from adult studies is not appropriate, as both the spectrum of liver diseases as well as the hemostatic system itself differs between children and adults. And the rebalance model that we mentioned does not work. So these are the laboratory studies that is used to evaluate hemostasis in pediatric liver diseases. So to assess the procoagulant, we do the PT, the INR, we do fibrinogen, proteins S, C, antithrombin, the dimers, platelet count, and also we assess the vascular blood flow and the endothelial function by the von Willebrand factor. All this is important, and this is important workup in patients who will be transplanted. Okay, approaches to the treatment of bleeding in liver disease. As we know, replacement therapy, fresh frozen plasma, cryoprecipitate, fibrinogen concentrate, platelet transfusion, recombinant factor 7 or Novo-7, prothrombin concentrate, vitamin K replacement, antifibrinolytics. Tranexamic acid is really good, it works wonders. But then, this does not always solve the problem. We need to understand more. And sometimes patients, for example, take FFPs, and it leads to volume overload and it's not indicated. So, take-home messages. Children with liver disease can develop severe bleeding episodes and thrombosis. Liver failure usually results in decreased levels of procoagulants and anticoagulants. Additional risk factors are important for developing thrombosis. Detailed studies of hemostatic disturbances in the setting of pediatric liver disease are sparse, and extrapolation from adult studies is common. The spectrum of liver diseases and the hemostatic system differs between children and adults, and the collaboration of the hematologist and the hepatologist is very important. Managing those patients, and thank you.
Thank you Dr. Magy for يعني highly scientific build up very الحقيقة sensitive يعني coagulation cascade ده كان من الحاجات اللي دايما بتبقى Thank you so much. The floor is open for questions.
شكرا دكتوره ماجي على المحاضرتين القيمتين دول. برضه انت عملتي زي مصطفى الهدهد، كان السنه اللي فاتت المفروض تديهم لنا بس ما قدرتش تيجي السنه اللي فاتت، الحمد لله اديتهم لنا المره دي. عايز اسالك يا دكتوره ماجي، كان جه ايرا كده من few years of factor 7 transfusion for coagulopathy. Is this era still present؟ لان كان بيدوم في الليفر فيلير وكان very expensive و very costly، ويعني is this era of factor 7
subject of debate حضرتك. هو دايما حضرتك يعني احنا دلوقتي دايما بنعتبر النوفو 7 الدواء السحري في حاجات كتيره. يعني مثلا هقول لحضرتك حاجه بعيده عن المجال ده، مثلا في الكارديوثوراسيك سيرجري any unexplained bleeding ادي نوفو 7. sometimes it works. patients in the ICU يعني انا been consulted before على patients in the ICU with unexplained bleeding وفعلا we gave novo 7 and it worked. There is so much to understand about recombinant activated factor 7 that we don't understand. ومن ضمنها مثلا اقول لحضرتك experience برضو بتاعتي انا علشان الرير coagulopathies ففي الفاكتور 7 deficiency. اوكي في الفاكتور 7 deficiency احنا ممكن البيشنت بيجي لهم intracranial hemorrhage وممكن بنحطهم on prophylaxis. الهاف لايف بتاع فاكتور 7 قد ايه؟ قد ايه؟ من 3 ل 5 ساعات.
يس.
طبعا يعني it doesn't make sense يعني. طب احنا بنحطهم على weekly prophylaxis it works. في ناس ممكن بيقعدوا by week يعني fortnightly او every 2 weeks وساعات even 1 month. الاكسبلانيشن بتاعي انا ان it has a cumulative effect بمعنى ان it can stay in the body for quite some time and it works رغم ان الهاف لايف بتاعته it's quite short. بس لسه الكلام ده مش evidence based، ده my theory يعني. فزي ما حضرتك بتقول يعني في بعض الحالات in unexplained bleeding and severe bleeding we can give it a try. We've got nothing to lose but we can lose if we don't try it. لكن اليوز بتاعه is subject of debate. وكل الريبليشن كده انا حتى I did not comment عليهم ولا على الدوزنج ولا حاجه، كل الحاجات دي والسبورت بتاعها يعني subject of debate جدا. يعني انا في عندي patients Gaucher disease بيخشوا يعملوا endoscopy وعندهم impaired coagulation profile without any preparation. يعني فحضرتك الحكايه دي فعشان كده يعني فعلا يعني كلام حضرتك ده مظبوط. يعني اكشولي الرول بتاعه subject of debate.
سؤال تاني بعد اذنك دكتوره ماجي، احنا كهيباتولوجيست بنريكومند البلازما انفيوجن في العيان عنده prolonged INR twice a day يعني every 12 hours. is this يعني في الهيماتولوجي ماشي ولا انتوا بتدوا يعني على فترات اكتر؟
لحضرتك عايزك توصل فترات اكتر مش فاهم.
العيانين عندهم كواجولوباثي.
لا يعني فترات اكتر يعني فترات اكتر يعني
اكتر من 12 ساعه مثلا every day every other day يعني is it mandatory الهاف لايف بتاع البلازما ما يزيدش عن 12 ساعه؟
لا يعني هو دلوقتي هل مثلا العيان هيعمل
عيان in liver failure
ولا
yes.
ولا ده كرونيك ولا يعني
no he's in liver failure and his prothrombin time is prolonged and are prolonged فبنديله البلازما replacement every 12 hours.
is he a bleeder؟
نعم.
هل بينزف؟
بنديه طالما الاي ان ار عالي عشان بروفلاكسس اجينست بليدنج يعني.
طيب ما هو دلوقتي حضرتك سي ان دوت عيان كرونيك، ده عيان كرونيك ده اللي انا بساله. العيان كرونيك ده طب هيقعد قد ايه ياخد بلازما every 12 hours؟
That's what I'm asking. هيقعد قد ايه وهاو فريكوينت؟
لا ما هو ده بقى حضرتك دوت التوك ديت احنا وي نيد تو ستادي الكلام ده، لان زي ما بقول لحضرتك انا في الاكسبيرينس انا ممكن العيانين دول so long as he is not bleeding I'm not correcting the lab.
Yes.
I'm correcting the bleeding symptom بالظبط.
Yes. So long he is not bleeding, you don't infuse him بقى بالبلازما لغايه ما
عشان الفوليوم اوف فلويد وحاجات كتيره جدا and he is not going to stay for life عليها حضرتك.
Yes. Thank you very much.
You're most welcome.
اتفضل يا جماعه.
شكرا دكتور ماجي. سؤال why you say that you give vitamin K only to the breastfeeding? I know at the delivery room, all newborn infants receiving at one side vitamin K prophylaxis and the other hepatitis B vaccine to guard against early neonatal hemorrhage. Thanks.
لا حضرتك انا قصدي معلش سوري هي we can give all babies it's no problem.
هل سعادتك البروتين سي ديفيشنسي في النيونيتال بيعمل نيونيتال بيربرا فالمنانزا غالبا بيتكرر حضرتك كل هو اوتوسومال ما اعرفش انا مش فاكر يعني
البروتين سي ديفيشنسي حضرتك اوتوزومال ريسيسيف
اوتوسومال ريسيسيف
بالظبط. طيب هو دلوقتي حضرتك القصه ان هو البيكتشر بتاعته هو بيعمل ماسيف سكين نيكروسس.
ايوه
والبيكتشر بتاعته هو اتس كوايت رير بس طبعا احنا عشان تيرشري هوسبيتال وعلشان احنا البوبيوليشن بتاعنا فاحنا ديفينتلي بنشوف البروتين سي ليس بالقليل يعني. فهم وهو المشكله برضو ان هو لازم ان بياخد بلازما بروفيلاكسيس او يفضل يحصل الريكورنت نيكروسيس او البروتين سي كونسنتريت بس ده مش افيلبل في مصر.
شكرا.
العفو.
شكرا.